Hello, I'm Dr. John Cruz, and today this is a question and answer session based on the video I released 2 days ago about tolerance to stimulants. So I'll recap that video in probably 2 minutes or so, and then I'll be open to questions on that topic or any ADHD or other mental health questions. So tolerance is simply defined as the body adjusting to an external medication or other stimulation so that the effect of the original size of stimulation or dose of a medication has a smaller effect over time. So you effectively need a bigger dose to get to the same effect. And with medications, there's probably two different pathways that occurs. So tolerance to something like alcohol is primarily, so many people notice after their first year at college, they can tolerate a much bigger amount of alcohol than they could at the beginning of the year. That's largely because enzymes that break down the alcohol have been induced, so you're breaking it down more quickly, so your blood levels never get to as high a level with the same dose. The other general form of tolerance develops through changing receptor numbers up or down or transporter molecules, and the concern with stimulants pertains mostly to the dopamine transporter, often abbreviated as DAT, DA for dopamine, T for transporter. So that's the molecule that's most responsible for the immediate concentrations of dopamine in the body or at the synaptic level. Um, so the cell that's using dopamine releases it into the synapse, travels to the second neuron, has a reaction, and that would keep on going and going if there wasn't a way to end it. There is some breakdown of dopamine by monoamine oxidase and other chemicals in the synaptic space, but most of it is that dopamine gets taken up by the cell that released it by the dopamine transporter. And our stimulants are drugs that block the dopamine transporter. So they block they are reuptake inhibitors. We don't call them that. I'm not quite sure why, but that's what they are. So there's a very strong analogy to serotonin reuptake inhibitors. Anyway, dopamine reuptake inhibitor, dopamine transporter takes it up. And the concern is there was at least one paper 13 years ago, or 2013, by Nora Volkow, who's the chief of the National Institute of Drug Abuse. She's a very famous and appropriately so researcher, has done brilliant work and a good administrator. And in this paper, it was a long-term study, longer than most. So there were, I think, 18 people with ADHD, never treated before with medications. So at the baseline, these 18 control subjects or 18 ADHD subjects and 11 control subjects who did not have ADHD, dopamine transporter density was measured, particularly in the striatum, deep in the core of the brain where there's dopamine cells. And then the ADHD group was treated with methylphenidate. It was on a flexible dosing schedule, so it was whatever worked for that individual. And at the end of the year, they checked where dopamine transporter levels were, receptor density, um, transporter density. And there was a 25% upgrading or upregulation in the ADHD population exposed to methylphenidate, Ritalin, than there was compared to the base or the control group who didn't show any differences. And that finding in and of itself would suggest that there's some tolerance that has developed. And the worry is if you're developing tolerance, that means people will need to keep escalating and take bigger and bigger doses. It also means that when people miss a day or two, they're not only potentially left at their baseline, but they may be more impaired from their ADHD than they were otherwise. So the study, to the extent that was done, was well done, but there's a few big gaping holes. So they did control between the control group and the ADHD group, between age, between socioeconomic status, but gender, they were markedly skewed. So the ADHD group only was 33% men, whereas the control group was 82% men, a huge difference. And that's significant because some studies have found gender differences in dopamine. There are also um, dopamine transporter differences across the menstrual cycle. Nothing in the reports stipulated what time of day samples were taken. There are dopamine circadian rhythms, there are dopamine annual rhythms, dopamine transporter rhythms. So, and the somewhat confounding thing is that most studies have found that at baseline, people with ADD, the thought is, tend to have lower levels of dopamine at the receptors and higher levels of dopamine transporter trying to make up for that or compensate for that to begin with. And in this study, the control group and the ADHD group were in the same place to begin with. So I mean, it makes it very hard to interpret this study or know how replicable it is. Other studies have some have found similar results, some have found different results. Even if there is tolerance, it's not clear how quickly that disappears after stopping stimulants. There's just a handful of studies in rodents and in humans suggesting, at least at the level of the dopamine transporter, that can adjust fairly quickly within days to weeks back to normal, even after a prolonged period of taking stimulants. And I included in the talk my own, I've been going on more than 2 minutes. My own observation is in agreement with most of the ADHD experts and disagreeing with most of the drug abuse experts. The drug abuse experts say pretty unanimously that everyone develops tolerance to stimulants. Everyone's going to need to escalate dose. The ADHD experts tend to say the opposite. And my numbers were of people who were stable at one point on a dose of stimulant, 80% of them were on that same dose a year later. And of those 20% who needed to change dose, some were up and some were down. So, is tolerance potentially an issue for some people? Yes. Is there possibly a difference between high levels? And this 2 weeks or 3 weeks ago, I had a video on high levels of stimulants, which ties into this topic. Maybe being on an ultra high or euphoric range dosage makes it more likely that tolerance develops than if you're in a quote therapeutic range. But lots more work needs to be done to nail down what's going on with tolerance or not. So I see there are some questions, so I will jump to those. Um, so Dennis is saying, thanks. It's a little bit of what goes up must come down. The med has raised levels of neurotransmitters for 8 to 12 hours, and it wears off, leaving the neurons in a state of reuptake and repackaging them. I'd say that sounds reasonable. So Frederick Weaver asks, are there any studies which look at behavioral endpoints as opposed to dopamine transporter density that suggest that stimulants lose effectiveness? Um, so getting back to the Volkhaus study, one nice thing they did is actually look at, um, they tracked that individuals did have every aspect or angle of ADHD symptoms, so hyperactivity, inattentiveness, impulsivity, all of those decreased in response to the treatment. But I don't have at the tip of my finger. I mean, one is doing repeated studies is expensive. So most often studies look at a very few time points. Um, my recollection is some of the childhood large ADD medication studies seem to find somewhat less benefit at the end of more than a year than they did early on, but I don't have those numbers at the tip of my fingers, which I probably should. So Steve asked, with the Volkov study, was there a difference between stimulant tolerance in males versus females? So again, the sample sizes were pretty small. There were only 18 ADHD subjects, only 11 controls, so they did not break them down by gender. And again, it would have been really difficult because to do mathematical comparisons because they weren't similarly broken down. in the ADHD sample was two-thirds women, whereas the controls were only 18% women. So it's breaking down subgroups is going to make it even less likely to be statistically significant, but none of that was broken down in the report that was published. Hello, Maximus. I've been wondering if we assume ADHD is just a group of symptoms, it means it may have different causes depending on a person, and yet we mostly treat it the same way, stimulants. How come? So, really good question, and part of that is not specific to ADHD, but pretty general across psychiatry. So, psychiatry, there are a number of conditions, schizophrenia, depression, ADHD, where we can find group differences. So, on average, is dopamine transporter density higher in ADHD people than in controls, age match controls? Yes. Are there unusual wiring patterns or activation in frontal cortex? Yes. But are those differences robust enough that they are separating clearly everyone? Can you take a single measure and say, ah, this is so high, it must be someone with ADHD, and this is so low, it has to be a control person without ADHD? No, we can't do that. We don't have definitive markers. But that doesn't mean we don't have, so we have what we have right now, I would say, are loose correlations between symptom clusters, but those are clearly associated with patterns with dopamine neurotransmission, frontal cortical, prefrontal cortical circuitry, and correlation between symptom severity does seem to track with some of these measures. So it's not as simple that we only have symptomatic measures. And clearly, the NIH and others are trying to move away from our current diagnoses because the claim is that ADHD, depression, probably schizophrenia are a multitude of different things that get lumped together because they look similar. But again, there are overall group differences we can find in wiring and anatomical size, even of some structures, of neurochemistry. Again, none of those differences are big enough. So it's not that we're only dealing with symptoms. Those symptoms do seem to track or reflect some basic neurobiology, and the NIH is trying to steer us more towards exactly that kind of tie-in, where we can find symptoms that seem to relate to a specific neurochemical or neurocircuit origin, and looking at mental health conditions in a more dimensional way. That way, I might not have explained that very articulately. So Maximus goes on to ask, what if someone has these symptoms, which it's just ADHD, but it's, for example, some childhood trauma, anxiety, etc. Is it still ADHD? So this is all the topic of the book I'm working on and writing. Traditionally, we have been saying, ADHD is a neurodevelopmental childhood problem that most children don't outgrow. It has to start, symptoms have to be present before 15. They have to progress, they have to have a certain number of symptoms in these clusters. And people have questioned or brought up a label of sort of something like secondary ADHD. What if you have the exact same symptoms that happen to a 30-year-old because they got hit on the head and they have a severe traumatic brain disorder? Or what if, and this has been well documented, there are people who developed a post-COVID syndrome who previously did not appear to have any ADHD symptoms, and yet afterwards they have a whole range of executive function deficits, so problems with sustaining attention, directing attention, short-term working memory issues, impulse control issues, emotional regulation issues that don't appear to be depressed, don't appear to be anxious, and look like a ADHD picture. And in many cases of head trauma or post-COVID, it seems they even respond to the same stimulants, guanfacine, non-stimulant dopamine and or norepinephrine reuptake inhibitors. So I get that there's reasons we want to be precise and careful in our diagnosis, but I think we've made a mistake or we're not actually accurately mapping what's out there by saying ADHD is clearly way distinct and different than something that looks like ADHD that arrives from a different course. So, one other thing I'll say on this is that so much of what we rely on today are symptom checklists, symptom checklists. And I would argue part of your question, you can't make an ADHD diagnosis based simply on a symptom checklist. That can be supportive, that can be useful, but you absolutely need the time course. When did these symptoms develop? Over what time? What age? Are there certain situations that make them better or worse? So I'd say usually we can separate out anxiety, depression, childhood trauma. Um, I mean, with childhood trauma, you need a history of there had to be a trauma, and your symptoms had to start showing up after that trauma. They can't show up, be present full force before, and then you can blame or attribute it to the trauma. So, again, longitudinal time course is important, and what situational factors change or don't change the symptomatology. So I can talk more about that. I'm not sure if I address the specific question that was asked, but I'll move on. And so Steve is coming back to ADHD tends to run in families. There's a strong genetic basis for it. But babies born premature, like myself, have heard of higher incidence of ADHD. So so one thing, modern statistics are keep advancing, and we claim that we have tools that can figure out or unmap confounding variables, but this is really difficult. So, one part of mothers who have ADHD are more likely to have preterm babies. Part of that is because this is a gross overgeneralization, but poorer self health care, poorer diets, higher rates of drug abuse. So, then it becomes difficult to map out, is prematurity itself coming from the ADHD? Is it coming from associated behavioral associations that go with the ADHD but aren't the ADHD itself? And then the second factor with prematurity is that separate from situations in which the mother has ADHD, prematurity itself is suggesting something was going wrong or aberrantly in the normal in utero developmental process, that the mother's body or the fetus's brain and body were saying it's time for me to get out before it's normally time to get out. Um, Things like infections, things like trauma, things like probably metabolic abnormalities, all of those are also contributing factors to prematurity. And it's hard to, and having babies either delivered by C-section or being delivered vaginally the normal route, if your brain and body are at 6 months rather than at 9 months developmental stage, they are much more fragile. They are much more susceptible to trauma and damage. Its health is a risk factor for ADHD. So, absolutely, studies been pretty consistent. More common among premature infants. Still, the majority of those infants do not have ADHD, but it's a higher rate than the background population. And again, how much of it is due to underlying genetics, underlying ADHD, underlying other conditions, and how much is prematurity in itself the risk factor is hard to sort out. So I don't know if, yeah, and so I'm not being, I won't overshare, but my 21-year-olds who are healthy and happy were born before the end of the second trimester. So I do have some personal experience with prematurity and neonatal intensive care units. They're happy 21-year-old twins. Jumping back to Maximus, I wish there was something like a brain scan test which could tell if it's ADHD. Yeah, that would be nice and helpful. Certainly, and I mean, there's a practitioner in Northern California who has clinics in other parts of the country too. And for more than 25 years, he's been claiming he has PET scans that can definitively identify ADHD or one of 7 or 11 or 9 different types of ADHD. If you look at the small print of his claims, there's enough weasel words that he's not directly saying that, but almost everyone, even educated medical professionals who listen to him, come away with the impression that he has claimed that he can identify with PET scans by different activation in different brain areas what's different varieties of ADHD. The downside is that other laboratory people, bright people at Stanford, at National Institute of Mental Health, haven't been able to replicate this. And I've been underwhelmed by patients who've gotten PET scans under this treatment center's approach, how poorly they actually account for individual differences or variation. I can get into some of that if people want, but I won't. Um, So yeah, it would be great. It'd be even simpler if we had a simple blood test, or if we had what was the Star Trek, a transponder that you could just wave over. I mean, brain scan takes time. That's invasive. If we had some other test, my belief is that Apple and Google and all our other internet friends probably have a much more detailed, precise, and accurate assessment of who have ADHD, because measuring the micro deviations of how quickly you're typing things in a row, looking at where your eye gaze is being directed, how quickly you're being pulled off track, how extensively you get pulled down a rabbit hole before you get back to your original track, if you ever do, how much your head's bobbing, and not just of that dimension, but even tinier micro movements. That's a huge, rich trove of biobehavioral data that I think will probably at least as accurately sort out ADHD as we do now clinically. But they're not sharing their data right now. Um, any any other questions coming in? Okay. Anything else to say about tolerance? Any random questions about the dog who's just jumped off the chair? So I'm happy to talk longer if someone comes up with a question in the next few minutes. I will probably be preparing a talk on N-acetylcysteine for this weekend at NAC, because there have been questions about that. The other topic that I've gotten lots of questions on has had to do with perimenopausal changes. I'm not sure that there's actually a lot of hard data, and I know it'll be a few weeks before that one comes out, but that's a topic I've heard lots of questions about. Again, my summary of Volkov's research is that it's moderately interesting. Again, it was a 24 or 5% up regulation of dopamine transporter in striatum and I think putamen, parts of the striatal corpus striatum deep in the brain where dopamine cells are. But what that's significant, one, how generalizable it is, two, how long-term meaningful it is hard to decipher. I'd say overall, looking into this area again, I think that tolerability is, or tolerance is maybe in terms of everyone needing to go up on the dose. That doesn't seem to be clearly the case, but it has alerted me or made me more aware that for many people, feeling that their brain isn't working as well on a day or two off of it, usually my likeliest inclination was to blame that on more a perceptual issue that you've been functioning really well on the medication. And now on the days off of it, you have more insight and awareness because of being medicated to evaluate um, how poorly you're operating off of it, and that's hard to compare how poorly this day was compared to 6 months ago or 3 years ago. But I think increasingly that it isn't just a psychological comparison factor, but that some people pretty clearly are dealing with physiologic tolerance, and at least for a few days after stopping regular use, their brain is in a slightly different place, which may be a worse place. And again, that's worrisome because that contributes to more and more regular use. And most evidence for addictive processes suggests the more you are using, the more prone you are to running into problems. Again, most people, even for decades on standard to robust dosages of stimulant medications, do not become addicted, but some do. So I'm not seeing any other questions coming in. Um, Thank you for the questions that have been offered today. They're all good and thoughtful ones. I'm even happy to entertain non non thoughtful questions. And I will be back every Tuesday. So I will wrap it up today and stay healthy, stay happy, and we'll be back next week.